एम्स का ही कंट्रोल हो रहा है.
Requesting everybody to be on mute. We go live in 30 seconds.
Okay.
We are live.
I welcome everybody on this international webinar. This webinar is on iBanking, corneal surgery, and COVID-19. And it is my privilege to introduce the speakers and the panelists of the webinar to you. But before I do that, I would request Professor Maipal Sachdev, who's the president of All India Ophthalmological Society, to say a few words. This webinar is a collaboration between the All India Ophthalmological Society as well as on the platform of iBank Association of India. So, sir, will you just say a few words?
Yeah, thank you very much, Dr. Namrata, and welcome all of you to this webinar on iBanking, corneal surgery, and especially related to COVID also. Today's this webinar is actually involving 5 countries over 5 continents and with all the major institutes of India and the eye banks of various countries that have been represented. We are really thankful to Dr. Rajiv Garg, who is one of us and is the Director General Health Services of India, for having joined us. Apart from that, you will be having all the major institutes participating in this. Also, there is the zonal representation from the Eye Bank Association of India. And essentially, I think because of the COVID, the eye banking activities have really gone for a real into a back burner as things stand just now. So I think we have to recoup, regroup, and re-emerge from the COVID and start the eye banking activities and to do the corneal grafts in a safe manner, safe both for the surgeon as also to the patient. So I think discussing all this from across the globe, as I said, across 5 countries and 5 continents, we have this webinar, and I thank everybody for having participated in participating in this. Without much ado, I think I'll pass it on back to Dr. Namrata, who is really doing a great job in organizing these various sessions. And let us hope for a good interactive session today. Thank you.
Thank you so much, sir, for always being at the forefront of all the activities that have happened during the COVID times at the All India Ophthalmological Society, and also for helping with the eye banking guidelines in collaboration with the Eye Bank Association of India, the Cornea Society of India, as well as the ISCRIS, Indian Society for Cornea and Keratorefractive Surgery. I would also like Dr. G. Mukherjee to give a welcome address again from the Eye Bank Association of India. He's the president of Eye Bank Association of India. Dr. G. Mukherjee, sir. Okay, I don't see him. So I think I will introduce the participants of the webinar. So we are doing, we just want to know how the international experts are planning eye banking and corneal surgery in this COVID-19 era. And we have with us eminent chairpersons, Dr. Rajiv Garg, who's the Director General of DGHS, Ministry of Health and Family Welfare, Dr. Pramila Gupta, who's the Principal Consultant, Director General of Health Services, Ministry of Health and Family Welfare. And apart from this, of course, we have the 2 presidents, Dr. G. Mukherjee, the President of Eye Bank Association of India, and Professor Maipal Sachdev, the President of All India Ophthalmological Society. Then we do have Dr. Samar Basak, who's the past President of Eye Bank Association of India and is the Director of Disha Eye Hospital, which does the best in terms of the hospital cornea retrieval program. Then we have Major General Dr. JKS Parihar, who's the Vice President of Eye Bank Association of India and former additional DG AFMS and Professor of Ophthalmology. Then we have Professor Rajesh Sinha, who's the Honorary Treasurer of All India Ophthalmological Society and the EBI. Then amongst the speakers, we are delighted to have an international group of speakers with us. Dr. Graham Pollock, who's the Director of Lions Corneal Donation Services, Melbourne, Australia. He's also the founder member of the Global Association of the Eye Banks, GAIBA. Ms. Heather Machin, the Global Alliance of, representing from Global Alliance of Eye Bank Associations. Then Dr. Benny Jeng, who's the Chair, Department of Ophthalmology and Visual Sciences, University of Maryland, School of Medicine, USA. Dr. Jill Stewart, from Professor of Ophthalmology, University Hospital of Saint Etienne, from France. Then we have Dr. Rita Gururang from Telangana Institute of Ophthalmology, Kathmandu, Nepal, and Mr. Patrick Emery, who's the Vice President of Asia and Ethiopia, SightLife, USA. Then amongst the panelists, we have Mr. Eric Hiller, Global Development Director, Eversight, USA, Dr. Quresh Muscati, who's the past president of AIOS, Dr. M. Srinivasan, who's a past president of EBI, as well as representing the Arvind Eye Hospital from Madurai. Professor Jeevan Singh Tityal, who's a professor and head cornea, cataract and refractive surgery services and chairman National Eye Bank at RP Center. Professor Radhika Tandon, who's professor in charge cornea, cataract, refractive, ocular oncology, low vision services, co-chair National Eye Bank, RPC AIMS, and also the immediate past president EBI. Professor Ritu Arora, who's the director of the Guru Nanak Eye Center, Delhi, and again has played an instrumental role in the HCRP program, and her hospital was also the COVID hospital. Dr. Rajesh Fogla, who's a consultant at Cornea Clinic, Apollo Hospital, Hyderabad. Dr. Rishi Mohan, who's the outgoing treasurer of Eye Bank Association of India, Eye Tech Institute, Delhi. Dr. Geeta Iyer, who's representing the Shankar Netralaya, Chennai, along with Dr. Rama Gopal, who's the director of the cornea services at Shankar Netralaya, Chennai, and Professor Arun Jain, cornea cataract and refractive surgery from PGI, Chandigarh. Apart from this, we have our zonal chairpersons, Dr. Hemant Kumar from Central Zone, Dr. Hitendra Ahuja from North Zone, Dr. Rekha Gyanchand from South Zone, Professor Rakesh Shah from West Zone, Dr. Sujata Das from East Zone, and Dr. Sunita Chaurasia, who's representing the LV Prasad Eye Institute and Amaya International Eye Bank. Apart from this, we have from Narayan Netralaya, Dr. Sharan D'Souza, Dr. Manisha Acharya, who's a medical director from Shroff Charity Eye Hospital, Dr. Swati Tomar, medical director, EBSR Jaipur, Dr. Ashiana Narayani from KEM Hospital, Mumbai, and our people who are from Eye Bank Association of India, Mr. G. Ganesh, who's the executive director, and Ms. Rakhi Nathawat, who's also helping with this webinar today. So with this introduction, I would now request Dr. Rajiv Garg, who's the Director General of Health Services, to give a few remarks.
Thank you, Dr. Namrata. I'm glad I was given a chance to speak on this occasion, and we in the Directorate have been very active, proactive for getting back to the new normal. That is because of the pandemic, we have been facing so many difficulties, and there is a pile-up of and backlog of patients. So, but it's high time that we go back as fast as possible, because the pandemic is here to stay. I mean, it may weaken, but it is going to be there for some time. So ideally, of course, most of the other, the transplantation activities are on hold. But for the eye, the number of patients, we have a very long list, particularly in our country, and with the present status, with all the universal precautions and some changes in our operation theaters, we can, I think, go ahead. We should, of course, the government guidelines are all there, but we are going to issue further guidelines as far as the ophthalmic practices are concerned. And of course, the major changes will be that you have to, right from the beginning, start screening the patients. And the screening team has to have more of the PPEs, and then you have to social distance. You have to have all the universal precautions. And when you are in the OT, you have to roster in such a way that you have the minimum staff possible. So again, the exposure to one another, because sometimes the virus strikes when you are not in the symptomatic phase. So the duty roster of all the healthcare workers has to be made in such a way that the minimum of staff has to be in the OT, and that anyway is good for the sterility as such. And generally only one OT should be started, one table, and there should be a gap. And in between cases, there has to be the proper disinfection of the OT table, the floor, and the usual. And the air intake, the AHUs have to be readjusted so that there's more use of increased fresh air. That's in the OPDs, in the outpatients, inpatients, in the labs, as well as in the OTs. So these are the few things, which should be highlighted in everybody's day-to-day practice. And I think this is the overview I could give, because the time is short. So I hand it over to Dr. Namrata.
Thank you so much, sir. Thank you. And we all are aware that HCRP has been allowed in a limited manner, but people want to know, especially in the green zones, whether they can start voluntary eye donation or not in those areas. So I think the ministry has to come out with these guidelines. I'm sure you will give us a directive also regarding the same. I would now, yes, sir.
Yes, actually, the latest situation is the HCRPs is allowed, but anything going into the field, because you may not know whether the containment zones are there. If it's a containment zone, then it is a strict no. And because the healthcare workers who go to collect the eye, you're putting them on a risk. So therefore, we are not allowing at the moment. But of course, soon as we are getting a serological survey done every month now. And once you know that the most of the people in a particular city are already exposed to the virus, maybe it could be done zone-wise, but not at the moment. Thank you.
Thank you, sir. And Dr. Pramila Gupta, Principal Consultant DGHS is with us here today. Dr. Pramila Gupta, ma'am, we would like to hear a few words from you as well. She said she was here. Anyway, I think there is probably some connectivity issue. We will begin with the program now. And I would request Dr. Benny Jeng to give his talk, the first talk of the day, that is the status of corneal surgery in USA. I think we all have to learn from each other and have to know what they are doing. They've already started. So Benny, would you please give your presentation on what is the status of corneal surgery in Australia? USA.
USA. Can everybody hear me? Yes.
Yeah.
So first of all, thank you to Professor Namrata for inviting me, as well as the panel for inviting me to present here today. I'll talk about the status of corneal surgery in the US in 6 minutes. I have no relevant financial interest to disclose. And, this pandemic has changed everything, right? In the last 6 months, things are completely different. This was Rich Abbott and myself in Taiwan, as what was normal, giving presentations just back in December. And now with coronavirus, everything is very different. Now we're doing this. This is how we see everybody. And while it's nice to be able to be in India right now for an hour, it's not the same. I can't talk with my friends afterwards and at the reception, have dinner. And then, on the practice side, things are very different. We, as cornea specialists, when was the last time we had to wear face shields in the operating theater? I don't remember that ever. So lots of things have changed for us. In order for us to understand how things are different in the US, I think a little bit of background needs to be understood about what goes on in the eye bank. And I think we might hear more about this. But this is data from the 2019 statistical report from the EBAA. And you can see from the early 90s to the mid 2000s, number of transplants, tissue that was procured in the US used for transplantation stayed relatively steady between 40 and 50,000. And then it started to increase steadily. And I feel like we're somewhat at a plateau, but it will almost hit 80,000 transplanted tissues used from US eye banks. So 50,000 in the US and 30,000 exported internationally. This is also very important for everybody to understand. This is in the US, everybody knows this. In 2011 was a inflection point where EKs took over PKs as the more commonly done procedure for keratoplasty in the US. And this is important in a couple of slides from now. So what happened during the lockdown in the United States? The biggest time period was from April to May. And so this is actually a bar graph from my own practice, our practice at the University of Maryland. And you can see here on average, we were at a certain level. In March, when the pandemic hit halfway through, our volumes dropped in half. And then in April and May, we're really locked down. We tried to do some telemedicine, but that was very, very difficult for cornea and retina stuff. And then in June, we opened up again to about 50%. And you can see our volumes increased a little bit there. So how did that reflect on corneal surgery in terms of what we did? Well, April and May, there was a significant drop in keratoplasty volume, not just in our institution, but across the country. In speaking with a very large eye bank in the US, they said that their volume dropped to 10% of normal. And what was interesting was that the ratio of PK to EK was much higher than usual. Remember the graph I showed you where EK was the more commonly done procedure? PKs were the ones that were predominantly done. Why? Because we're only doing emergent and urgent cases. And so routine endothelial keratoplasty was not being done, but perforations, only perforations were the ones that really were being done. So there was a change in the characteristic of the type of surgery that was being done, in addition to the volume dropping significantly. In June, the country basically went back to work at half capacity. The clinical volumes for most clinics were limited by being able to maintain social distancing. And so with that, surgical volume increased with the resumption of elective cases in most hospitals and ambulatory surgical centers. Kathy Colby, who is the president of the Cornea Society, polled us as board of director members in June and showed that in terms of the US, resumption of corneal transplantation, 75% of people were at 50% baseline or higher. So in the green and the purple, and 45% of Cornea Society board members were operating at greater than 50% of their normal baseline. And we have members distributed across the country in various different settings, so we use that as a representation. I re-polled the board of directors 6 weeks later, so just a couple of weeks ago, and this is what we looked at. We've advanced more even in July. Almost 90% of members are now operating at least 50% of baseline, with 75% greater than 50% of baseline. And of the 74%, half of them, so about 37% of cornea specialists, if we use the Cornea Society board members as representation, 37% are at 100% of their normal capacity. So over 1/3 of cornea surgeons are back to where they were before the pandemic for surgery. COVID testing 8 weeks ago was required only in about 72% of hospitals, and now it's almost 100%. So there's testing done and surgeries are resuming in the US. But what are the major concerns? Concerns of surgeons is, even in the US, donor supply and quality. We know that there's a rigorous screening program as there is in India and other parts of the world. And so we are worried about tissue being screened out. We're also a little bit worried about tissue that has not been screened out and whether or not the testing is 100% reliable. And are we going to be transplanting tissue that actually is from people who have COVID? And is it transmissible? There's data that suggests that there's not, but we're not 100% sure. Patients are having issues with having surgery during the pandemic. They don't necessarily want to come in to be exposed or infected for elective surgery. And for people who are coming from far away, there are restrictions of travel within between different states. And so people are concerned about traveling to go get surgery. And then a global worry in the US is about the second wave of COVID-19 that we anticipate will be coming later this year and forcing a second shutdown for elective surgeries. And so that's heavy on our minds here in the US. So COVID-19 has definitely changed our world, including corneal practice. But I'll say that in the US, corneal transplants have really restarted in the last few months, and especially in July, a lot of surgeons are now operating at normal capacity for corneal surgery. But the majority are probably still at somewhat lower than normal volume, although 50% is kind of a minimum for most people. There are still some concerns about availability of tissue and what COVID testing means, although the eye banks are very rigorous about testing for COVID. And then of course there are concerns about safety from the patient standpoint, as well as what might happen later this year with the second wave. With that, I hope that I've given you a little capsule of what's going on in the US from a corneal surgeon perspective. Thank you.
Thank you so much, Benny. So what we would like to know from you is that you are doing COVID-19 tests for all the donors that you are taking the corneal tissues from?
Yes.
Are you testing all the donors?
We are. We're testing the donors.
And you're doing RT-PCR for them?
It depends. We're still, I think someone from the eye bank may be able to speak better, but I know that all of our stuff coming in has been tested. And then our patients coming into the operating theater are all being tested.
Okay. So all diseased donors are also being tested with the nasopharyngeal swab, and then only you are allowing the tissue to be taken up for the corneal transplantation.
Yes.
Okay. So I think that is the biggest question that everybody wants to ask, and I thought before you leave, I might as well ask you this question.
Thank you.
Thank you. Any panelist or anybody would want to ask any question at this point in time? Benny, can you just remove the sharing?
Madam
Sorry.
I had a question.
Yes, Sunita.
The testing, what is being done, is it the RT-PCR or is it the antibody testing? And what is the experience with each of them? Like, what is the testing in context of the donor's history? So what are the results like, and how do we take that into implementation into donor cornea retrieval? Any thoughts on that?
Well, from a surgeon perspective, I think things are very complicated because they're not really clear cut right now. We're doing RT-PCR testing, yes, but sometimes we get false negatives. And there have been events where there's been testing that initially was negative and then turned out to be positive. So that's where my personal concern is the reliability of testing. I think in general it's pretty good, and if you get a positive, it's not going to be a false positive. I'd rather err on the side of caution. But what happens when you get a false negative and you don't know? And then we're not even sure that there's the ability for transmissibility, but still, before that's all established, that's going to be a concern.
So I can talk about, in our eye bank, we do testing on all of the donors as well. And we've made it pretty clear that we're not using this testing in the same way that we use like HIV, NAT testing, anything like that. Like this is not an end all be all. It is one data point. But we feel like it's an important data point to add on to the screening process and everything else that we're already doing. So I would caution against testing and using it as the sole determination for all the reasons that Dr. Zhang pointed out. There are false negatives, and that could be a concern.
Right. So each individual surgeon really needs to make the decision if they're going to do anything with that information. It is perfectly well stated that this is one point, one characteristic that we look at for the tissue.
Any modification in the consent form that you take from the patient in view of this COVID? Any modification that you have done in the consent form?
We have not. We have not done. I don't know if other people have done it, but we haven't changed it.
Are you talking the consent form from the donor or the surgical consent form for the recipient?
For the recipient.
From the recipient's concern.
Recipient undergo a corneal transplant.
Yeah.
What if the recipient gets...
Because there can be false negative. There can be false negative even if you do the test.
What if the recipient gets it due to some other reason and then blames your corneal transplant for it?
Yeah.
That's the only concern in the post-op period.
Yeah.
But our institution, we have done the, reform the consent, not only for keratoplasty, for other surgeries also. Now we do have a new consent for our COVID patients. I think that is mandatory now, as you rightly pointed out. Patient will be asymptomatic sometimes, and they may be negative with COVID testing. I mean, we never know patient who undergo surgery and subsequently they get exposed due to some other reasons, not because of hospital stay. We do require a good consent form. So that is what I think we have done it in RP Center also. For every procedure, we take a COVID consent now.
Just
Thank you
one
so much.
question. Yeah, Namrata?
No, I just saw Dr. G. Mukherjee, who's with us, who's the president of iBank Association of India, who's joined now. And I would like Sir to please say a few words before we proceed further.
Thank you, Namrata. I'm sorry for joining late because I did not get the link first. Now I got the link and have joined in. And good afternoon to everybody and welcome to everyone from the iBank Association of India.
Thank you so much, sir. Thank you for your presence. I would also now like Dr. Pramila Gupta, who's the Director General of Health Service, Principal Consultant at DGHS, has also joined. I think I saw her. Ma'am, can you say a few words? I think her connectivity is again lost. Okay. Thank you, Benny. And with this, we would move to the second talk.
Dr.
Yes.
Can I have one?
Yes, yes, surely, surely.
A recent paper in Corneal says that they have taken 11 tissues and studied it, and they didn't find any of the virus in epithelium, stroma, or endothelium. And they also end up with the conclusion that most likely the virus replicates or leads to lysis of epithelial cells. So my question to Banning is, do in America you are routinely taking off the epithelium, especially when you are doing PKs?
I do not, and I don't think most people do. You know, these studies are good; they're all coming out, and it's great. But I don't think that we know for sure. I mean, there's limited data in each one of those studies, and I think everybody has to make a decision whether they have enough information to decide that or not. But to answer your question, I do not, and I don't think that most people take off the epithelium for PKs. Although that would be an interesting thought to try to mitigate it if you're worried about it.
The study that Arun is quoting, only 10 cases were done in that study. It's a very limited number. Unless a large number of cases are done, one cannot rely on that case that there is no COVID virus, the coronavirus in corneal tissues. They have studied from epithelium to the endothelium.
Us here, ma'am, for your few words to the iBanking community of India as well as international experts that have joined. So we would like to hear a few words from you.
Thank you, Dr. Namrata, for listening, and all of you. Good evening, all of you. Actually, as we all know, as our Director General also has said, that we are still dealing with the pandemic and the cases numbers are still high, even though now in Delhi we are getting a decreasing number, but all over the country the cases are quite high and fresh cases are coming. So we have to be very careful, especially in our country, where the corneas majorly are collected from the field through field visits from cadaveric patients. So and our technicians are not trained to do a RT-PCR test through stored swabs of patients, and I think it will be too dangerous at this time to allow them to do. And so that is why currently we are not allowing any home collection of corneas or eye retrievals from home deaths, but only through HCRP, where the patient is known to be non-COVID. Because as it is, the RT-PCR test also is quite expensive, and doing it on all donors will be a bit too expensive. So in spite of the fact that we know that there is a lot of backlog of cornea, but to take care of our own health workers and patients, the recipients, that they should not get COVID-19 infection from the donors, we have to, currently we have to do with the fact that we cannot allow home collection of corneas in spite of from many quarters we have received requests, but I think at present we'll say a no to it. Thank you.
Thank you so much, ma'am. That's not very heartening, but we hope that will change in the future.
Yeah, definitely.
Yes, and now I would like to request our friends from Australia, because it's too late for them to give their talks. So I would like them to give their talks first. Dr. Graham Pollock, who's going to be talking about status of corneal surgery in Australia.
Thank you very much. I will just share my screen here. Okay, good evening, everybody. When people are probably getting sick and tired of me talking about, when I talk about iBanking and COVID-19, I keep talking about risks and relative risks and risk-benefit ratios here. And so as I go through this talk, largely I'm referring to the management of risk, both within the iBank that's being undertaken in Australia, but also the management of risk through our public health measures in Australia as well, which you'll see have quite a significant effect on the risk that we actually see at the iBank interface. And then go on and talk about the risk intervention consequences or outcomes of that, both from our own management of risk within the iBank, but also the public health interventions. And more recently, some activities that are occurring in some of the hotspots that we're now seeing in Australia. I think that we certainly have to put things very, very much in perspective here, that what we're talking about is certainly a possibility of transmissibility of the virus. In fact, every indication is that the virus cannot be transmitted by any form of transplantation. And indeed, there was never any evidence of transmission of MERS or SARS by any form of transplantation, or indeed blood transfusion as well. And as someone referred to before, we've also seen the absence of the virus in corneal tissues that have been obtained from COVID-positive postmortem donors. In Australia, the donor selection then has really looked at excluding donors who have symptoms of SARS, or if they of the virus, sorry, of COVID-19, or if they've had close contact with a person confirmed to have COVID-19. And we're looking at a 28-day exclusion period in Australia for that. This is very similar to the blood banks screening. For donor testing, in Australia, it's not recommended at all for screening donors. And this is because we have very, very much concerns about the validity and the reliability of the test, whether it in fact relates to infectivity, and also, of course, the lower incidence that you have of the virus in your demographic, the lower predictive value of it. And you'll see that's quite relevant to the Australian situation. Tissue processing. Making absolutely sure, and this is something that happens routinely anyway in all the iBanks in Australia, that at some stage, whether it's at retrieval, if it's an in situ retrieval, or indeed whole globes being rinsed with povidone iodine after retrieval, we certainly know that povidone iodine inactivates the virus, even at a very low percent of 0.23%. And in fact, the European Council for Disease Control considers this a validated disinfection step for enveloped viruses. One of the most important things, though, that we have in the iBank is an emphasis on PPE for our staff. In fact, the greatest risk that we have here is not risk that the cornea will transmit COVID-19. The greatest risk we have here is that we will infect our iBank staff during retrievals. Certainly if we have one staff member who contracts COVID-19, that essentially shuts down the iBank. One of the things where we have a very low risk is because of the public health response that we've had in Australia. The public health response has been very effective, and in most states of Australia, one would consider Australia to be essentially COVID-free now. Those figures that you see on the side here, the 100s and the 200s, they're not 200,000, they are 200. So a very, very low incidence of COVID-19 in Australia. Although more recently, we have seen a second wave, but I'll have a little chat about that a little bit further on. One of the consequences, though, and one of the parts of the public health response to this was to prepare for a surge of cases. And so elective surgery in Australia for a month or so, right across Australia, was shut down. In regards to corneal transplantation, it meant what we call category 3 or category 2 corneal transplants, that either routine corneal transplants or transplants for bullous are essentially stopped and ceased. And so that certainly, if we have a look at our figures of transplant activity and also donor activity from March through to June, you can see that during the health system contingency planning, the surge capacity, I think there was an anticipation that elective surgery was going to be ceased, and so there was a little bit of a rush to get surgery done before these transplants were, these electives were cancelled. Once we'd cancelled all the elective surgery, you can see that the figures dropped to about 51% of our past activity level in 2019. Although this wasn't seen across, that's an average figure for all of Australia. It varied across Australia depending on what state you're in. At the same time, of course, we saw a decrease in donation rates. A lot of that was self-regulated by the iBanks because they didn't have the need. Come May, when there was a gradual reintroduction of elective surgery, you can see that we got a surge again of transplants, and these were actually cases that were being done that were missed during their previous time when elective surgery ceased. Although what we also have seen is a drop in donation, and I'll have a little chat about that a little bit in a moment. As you can see, both the donor activity and the transplant activity was not equally felt across all the states of Australia. And in fact, in Western Australia, for instance, really there's been very little impact of COVID-19 on their rates at all now. Now, I spoke about the second wave before, and most of that second wave that you see in these figures in Australia are in fact the Melbourne metropolitan area, which is where I'm actually broadcasting from right at the moment. In Western Australia, South Australia, Queensland, and New South Wales, the number of COVID-19 cases per day you can count on one hand. In Victoria, though, we're surging at around about an average of around 400 to 700 cases a day for the past week. And that's had an interesting effect on the activity within Victoria. These are the Victorian figures out of my own iBank. You can see that, again, back in June when the lockdown ended, we had a surge of cases, scheduled cases being done. In July, though, we began to see patients self-cancelling themselves. There also the requirement for patients to be tested for COVID-19 before they came in for surgery also contributed to a lot of self-cancellation of cases. And so But by the end of this month, we've also seen electives shut down. The donor activity is interesting because, as I said before, back in March and April, a lot of the donor activity was a wind down on the iBank's behalf of actually deliberately reducing donor rates. In May, when the hospital activity was very slow because most electives were still not happening, but we had essentially probably excess staff within the hospitals during that period waiting for the surge that didn't come. We actually saw our referrals increase and our donors increase. But in the past 2 months, with both the electives coming back online and the hospital activity being increased, but now with the electives down again, and we've actually seen a reduction in referrals, but more concerningly, we've also seen a reduction in the consents that we're getting. And this is because this second phase has taken a different mood amongst the community. The first wave that came through, there was certainly a sense of shared community values here, but as the second wave has come through, our social capital, the social temperature has certainly dropped. Death and bereavement are complicated enough, but in the face of COVID going on at the moment with limited bedside visits, the bereavement is also different, and there's a lot of fear and anxiety out there at the moment. And it's actually leading to less consents being seen, and also less referrals of cases coming through. And as we go into late July now and August, in Melbourne, we're actually having hospital staff redeployed to other areas, in particular the aged care sector, out of acute care hospitals, because that's where the COVID is largely occurring. And so a lot of our referral programs for that reason are breaking down, as well as our consents breaking down as well. And we're likely to see more of that in July and August. The second wave, I would warn, seems to have very much a poor effect on social capital. As soon as your social capital drops, then your donation rate also drops. And I think that's probably a reminder that what we do is a very human thing. That donation is a very human thing, and as soon as some of those things get complicated and the feel of the community changes, then that affects what we do as well. Thanks very much for your time.
Thank you so much, Dr. Graham Pollock, and thank you. I think we all need to be, you brought out a very important thing, that when the second wave comes, people get more fearful, not only the patients, but the healthcare workers also. And I think that is something which we need to be wary of, because in India, it is still the first wave. And so second wave is a reality, and that is something which we should be aware about. I know it is late in Australia. Thank you for waking up so late in the night. And it is my pleasure to invite Ms. Heather Machen, who's again going to be talking about status of iBanking globally. And she represents the Global Alliance of the iBank Associations, the GAIBA.
So thank you very much, Namrata, and the iBank Association of India for inviting me to present today. I'm really honoured, even though it is close to midnight. You've got the manic Heather as opposed to the composed Heather. So I hope you'll have a bit of fun with this. I did know that every other speaker was going to talk about what's happening in every other country and show you different stats and different changes in the donor referral system. So I'm intentionally not going to do that. I'm going to take a different angle and talk about things generally, and then perhaps try and put a positive spin on this and perhaps how we can adapt ourselves. So anyhow, here we are, 2020. I was looking forward to it. This was the year of the Global Blindness 2020 campaign. We had so many celebrations, but not to be. So the 2020 that we actually got is a little different, but it's certainly a shared experience. And this is the only time possibly in our lives where we will actually have a shared experience, be it alone, it's still a shared experience. So where does that leave us as iBankers? Well, first of all, let's have a look at the need and demand matrix. Ideally, we should have several principles working simultaneously. So for example, access to tissue, testing, access to operating theatres, a plentiful supply of workforce, nurses, surgeons, for example, and of course, all of these things working at the same rate as the size of the population. That's ideally how it should be. And in several parts of the world, demand and sometimes need have been met. However, now with COVID-19, that might not be the place. In fact, demand probably won't be met all of the time, and needs certainly won't be met all of the time. These fluctuations will change, not based on nations, but based on specific locations, as Dr. Pollock just said. It's changing all across Australia. It's changing across every single country. So if you're experiencing that, you're not alone. Your wait times will go up, the delays will extend, and this is the new reality. It will be for some time. The interesting thing is every single person that's communicated with me about COVID in our field over the last couple of months, we have a shared experience. We all have issues with too many donors, not enough donors, no one in the hospitals doing the consents, no staff available, resources going to PPE, no flights. The list goes on, and this is a shared experience, and we're not going to get out of this on our own. We're not even going to get out of this as iBankers. We have to be part of the health system and recognize how uniquely and integrated we are into the healthcare system. We go one, we go all. So we have to work together, not just with iBankers and ophthalmologists, we have to work outside of that as well. So long term, what will the world look like? It's so difficult to know. I tried to be really prepared for this meeting and give you some really proper stats, but the thing is they change every day and every month. The global economy might retract. 5.2% seems to be the figure I'm finding today, although it might go to 7.2 in advanced nations. But even poverty rates, right now there's 734 million people who are below the poverty line if you consider the poverty at $1.90. There's estimates anywhere from 70 million to 100 million extra people added to the poverty line. I want you to think about what that reality will look like. Will we have people shifting from private health to public health? Will we have people able to afford the surgeries that we provide and the corneal tissue that we provide? Because not every country is as lucky as mine, where our government and our health insurance companies pay for their tissue. We have to consider this. It's absolutely soul destroying to think for some sectors, hopefully not ours, but certainly some other health sectors, that the work that we've done in the last 10 years, maybe even 30 years, has been completely wiped away. In fact, I read a stat today that this is the first time since 1988 that that poverty line has actually gone down. These are different times. It's quite overwhelming, and I wonder what it is I'm going to take on. So we have to find some way of being positive and using this time as constructively as we can. So we need to find a way to adapt, to help ourselves, to help those around us, but also thrive. We need to be valid today, but also find validity in the future. We need to adapt our health services. We also need to adapt our iBanks. So for example, at the beginning of the first wave in the USA, iBanks like Miracles Inside in the USA, they were putting together 3D face masks for their local health service. That's adapting, that's helping. Nurses in the iBank in Sydney, they were going into the front line. That's adapting, that's helping. Those iBanks that were moving staff into other areas, they didn't have to furlough staff. These staff were still being employed. This is a fantastic way of moving staff out to then move them back in when we need them. Think constructively about how we can be creative with our current and then our future steps. Consider also the humanitarian aspects. Now, the Global Alliance of iBank Associations has been promoting for quite some time the need to work together as a community. If we don't work together, we're not going to get anywhere. But the funny thing is with COVID-19, this is the catalyst to actually bring us together as a community. There is nothing stronger. Take this meeting, for instance. Here we all are. There's people all over the world with this meeting. It's bringing us together. We need to harness that. It's quite overwhelming. So also have some fun with it. My photos here are some fun that we have in Australia with our meetings. I encourage you to make the most of this opportunity to communicate with each other and have some fun with it. Also take the time to stop. Never again are we going to have the opportunity to do a hard stop and a real think about what it is that we want our sector to look like and what kind of world it is that we want to live in. Use this constructively and critically to examine your individual organizations, your professional associations, and also how you work as a nation or a region or a member of the global community. Consider, for example, where you sit with some of the seminal frameworks in this field, the Global Alliance Barcelona Principles for one, and also the Sustainable Development Goals. You may also have roadmaps that you're looking to work towards. Have a look at what your current plan is. And if you're not working towards those seminal recommendations, now is an opportune time to do it. This is a golden opportunity to review, consider, reform, and readapt and revamp our eye care sector and our eye banking sector for whatever this new reality is going to be. So get involved. Thank you so much.
Thank you so much, Heather, and thank you for such a late night session. If there are any questions for Dr. Graham Pollock or for Heather, I think we'll take them now because they will leave after this. So if anybody wants to ask anything.
So Heather, Gran, that was fantastic. Really, really great talks and great to see you. So the question about safety of our eye bank technicians is definitely of big concern. So my question to you is, how about technology? So we see in other spheres how drones are being used to safeguard, you know, blood products into different places that need it, medical supplies, sanitization with robots. How do you see the eye bank adapting technologically?
That's very difficult. I can't foresee a case where drones are going to come in and actually do retrieval operations. At least not this week. I guess we're using what technology we have at hand at the moment, which indeed is the PPE that we use, and that's basically our frontline protection against the virus for our staff, and also, of course, the usual processes that should be taking place in your workplace anyway. Social distancing, wearing of masks within the eye bank itself at all times, thorough clean downs of everything. These are all standard things that ought to be happening. But I think that there's certainly a re-emphasis on the use of PPE when our staff goes out to do retrievals, because that's when they're certainly most at risk.
I think the idea of the drone is very savvy and certainly very contemporary. It has been tried, as we know. There are lots of examples we see in the news of someone trying it here and there, but it's never really taken off. And I think a lot of that comes down to the security. If the general public knows that there's human tissue, and particularly if we're in a situation, maybe not so with eyes, but particularly with organs and those sorts of things, where it's it's very difficult to get hold of an organ, and so there's a lot of demand for it. So it makes my pessimistic mind go to a dark place where I'm concerned of people lobbing it down and taking it to a backyard somewhere to do some unscrupulous things. So that's a worst case scenario, but it's possible. So I think there are a lot of security and safety issues that would need to be considered when you're talking about drones, but it is a very novel idea. But keep thinking of those sorts of things. I mean, a few years ago, we would never have even considered artificial intelligence as something that would be coming into eye care. Yet at the research centre that Graham and I work in Australia, they're looking at how they can use artificial intelligence to do diabetes screening in outback Australia, where we just don't have staff. So certainly think broadly. Is there anything that we as eye bankers can do with artificial intelligence? Certainly not today, but maybe in time, that is something that we could look at. It doesn't help us with COVID for sure, but yeah, keep those broad ideas, consider them, but also think about the risk and the safety around those ideas as well.
Thank you. Thank you. Thank you, Heather. If there are no questions, we'll move to the next talk, which is going to be given by Dr. Jalis Surer. He's going to be telling us about the European Eye Bank policies, one threat, different answers, impact of COVID-19 on cornea donation and donor selection across Europe.
Hello, good evening, everyone.
Good evening.
I'm very proud to give you this presentation. I will speak on behalf of the European Eye Bank Association, mostly because with, can you see my screen here?
You have to share your screen.
Is it okay?
Yeah, it is.
Like this, okay. As I said, it's a very short presentation, and the title is, as you said, One Threat, Different Answers, the Impact of COVID-19 Pandemic on Corneal Donation and Donor Selection across Europe. And it's a very institutional work. We work with friends and collaborators from different European countries to build this work. And basically, we sent through the European Eye Bank Association network a questionnaire to 110 eye banks of 26 European countries to just obtain the number of donor cornea procured and assigned to a recipient during March, April, May 2020, and compared to the 2 previous years. And we also performed a detailed analysis of the stringency of the official national recommendations for donor selection. And we analyzed the different population of potential donors, donors with proven COVID history, donors suspected to have COVID-19, asymptomatic donors but at risk. And we also considered the importance given by this national recommendation on RT-PCR on nasopharyngeal swab. And the last point was the possibility to use the results of ante-mortem PCR. And we gave to all these items different scores, different marks to determine the stringency of these recommendations. And here are the results. There is a global activity collapsed by 50% over this 3 months period. And this study is highly representative of the European eye banking activity because 64 eye banks participated, and especially all the biggest eye bank participated. And we estimated approximately that this survey covered 95% of the European eye banking activity. And you can see on the graph here, the procured cornea and the distributed cornea. There is also, you can see the difference between the 2 parts of the graph because we are mainly using organ culture in Europe. And as you may know, in organ culture, the selection is very hard, and 40%, 30 to 40% of the cornea that are procured cannot be grafted. That's why there is these differences. But anyway, you can see that in this year, for March, April, and May, this is not a surprise, but this is now demonstrated, there is a huge decrease in activity. And we calculated that for these countries, European countries, nearly 4,000 people could not be grafted during this 3 months period. We also showed a very important interbank variability in the decrease in activity, and especially some small structure were less impacted by the pandemic than big structure, but globally there is this big decrease. And this page is the most important. In the map A, you have the decrease in the number of procured cornea from March to May with a color code. If you are in green, your activity was not very much impacted, like for instance in Germany or Austria, it was not, or Czech Republic, it was not much impacted. And if you look at Belgium, for instance, here, or France and Spain, there is a huge decrease. This is map A. In B, we represented here the pandemic severity estimated by the number of dead people per 1,000 inhabitants in June. And in C, we calculate this health authority answer. This is the score of stringency of national recommendation for donor selection. And we calculated correlation between all of this, and we also calculated partial correlation to see which was independent of each other. And what we demonstrated is that the stringency of national recommendation for donor selection had a very, very high impact in the reduction in activity, much more than the severity of the pandemic itself. This is the most important result. So this is my last slide. So of course, there was in Europe a severe impact of the COVID-19 pandemic on corneal donation and transplantation between March and May. There was a wide variation in donor selection algorithm across Europe, ranging from clinical screening to molecular detection, with very, very wide variation in health authority answers. And there is a significant impact of complex and hyper-secure algorithm on the breakdown of activity, even though no risk of transmission have formally been established to date. And for the perspectives, the survey now continue, and we will obtain data from the same banks for July, August, September, and October to see how the activity can resume. And of course, in parallel, some labs are doing fundamental research to establish the true relationship between cornea and SARS-CoV-2. This is my last slide, and I thank you very much for your invitation, and thank you for your patience.
Thank you so much, Dr. Thuret. I think you brought out a very important point, and that was the donor selection. Still, people are not clear all over the world whether it has to be done clinically, people have to screen, or whether it has to be done at the level of molecular detection, or whether the criteria are so stringent all across the world. But suffice it to say that all over the world, the corneal donation program as well as the corneal transplants have come down very drastically. We have now Dr. Rita Gururang, who will be talking about status of eye banking in Nepal in the COVID era.
Thank you so much. So I'm sharing my screen. Oops. Is it there? Oops. Oh. Hi, Dr. Namrata.
No, we cannot see the screen.
Yeah.
Yes,
Yeah.
it is there now.
There
No, but
it
the PowerPoint is not there. It is
Yeah.
the Zoom.
Yeah.
Yes.
Oops. No. Where is it? I'm so sorry. I'm technologically a little bit challenged. So please bear with me. Sorry. Oh God.
Meanwhile, there's a question from Dr. Rakesh Shah, and I'll put that to all the international experts. They want to know, Dr. Rakesh Shah wants to know, I think it is a question for all of us also. Is there any time period for which you hold on to the corneas, or do you quarantine them before you release them after taking the after taking the donor corneas?
Right. Hi, Dr. Namrata. Can you see my screen now?
Yes.
Yes. So I'm Dr. Rita Gurung from Kathmandu. I work as a corneal specialist in Tirunelveli Institute of Ophthalmology. So this slide I have put to set the context. Although my presentation will be very, very basic, because I was asked by Dr. Namrata to speak on the status of iBanking in Nepal. So Nepal iBank is the only iBank in Nepal, which is situated in Tilganga Institute of Ophthalmology. So this slide, as you see, that in January, February, we are doing all right, because the first case of COVID came at the end of December, and January, February, we are doing all right, but slowly in March, the COVID cases begin to creep on. So, and the government decided to lock down the country from March 24th, 2020. As soon as the lockdown started, the management in the Nepal iBank, what we thought in these three areas of our work. One was to protect the staff. Second is, by protecting the staff, somehow we have to run the iBank, and we had to really look at the sustainability of the iBank, which was really difficult in normal times, and in COVID times it is even worse. So the first thing what we did for our staff was the psychological treatment. You know, because there was so much of information in the beginning of the start of the COVID in Nepal, that everybody was bogged down with the information, whether that was true, not true, in the middle. So we thought that maybe we had to train our staff on the COVID-19, what the real situation is like. And the fear factor was so strong and so big that people would not even like to go out of their house. And how could they go to the hospital to retrieve the tissue? So we did several lectures by psychologists and psychotherapists and even psychiatrists to all the staff, to give them some kind of management skill, the stress they have. And we had a very regular communication between the management and the ground staff level. At the same time, what we did was, it was all because we didn't have any patients in the hospital, so we spent all this time training our staff on what to do. You know, the Nepal Ophthalmic Society came up with the guidelines, and we had the iBank Association of America guidelines, and Indian iBank Association of India guide, WHO guidelines, Tilganga guidelines, and there are so many guidelines. So nobody knew what things to follow, but we told them that everything has to be followed strictly. That's what we did. Even for the iBank staff, others were not allowed to go on the streets, and they were harassed by the policemen in the street. So we had to get the permission from the authority for the iBank staff to move about. And we talked a little bit about the PPE, and we were in a little bit better off position than other hospitals or even other countries, because we had quite a long time from December end to March, quite long time for the prepare ourselves to the thing. So the PPE not only gave them the protection from the infection, but that PPE which we provided to the staff gave them some kind of moral boost or moral support, so that they could go to different hospitals for their work. So that was for the staff safety. For the operation of the iBank itself, it was very partial, because we have several donor hospitals, but in those donor hospitals we have 2 shifts running in the normal times, but we cut down to 1 shift, and only one eye donation council in those hospitals. And because they had to get some tissue somehow, following the guidelines, our iBank followed the iBank Association of America guidelines for the tissue retrieval. because there were some hospitals doing emergency corneal surgeries. So for them, we needed the tissue, and we did not allow them to use their logics. I don't know whether that was the right thing to do or not right thing to do. We just asked them to follow the very strict following of the guidelines. And for the patients who had surgery during this time period, all the corneal surgeons, at least from Tilganga, gave their cell phone to the patients so that they could call the surgeons whenever they have any problem with their transplanted corneas. And for the sustainability part of the business, which is again Tilganga Institute of Ophthalmology, which is quite big, but because Tilganga itself, which doesn't get any remuneration or any subsidy from the government, did the 50% subsidy to all the processing fees of the corneas, and but the number of corneas were very small, and the patients, there were no patients who wanted to have the surgery, and there were no surgeons who wanted to do the surgery because in the beginning everybody was panicking. So but at the same time, what we thought in the eye bank is we have to keep the momentum of the eye bank going, but at the same time, if we collect more corneas, maybe the risk will be higher. At the same time, the risk, financial risk will be higher too. So we did not encourage the eye donation counselor to do a lot, but they had to do something. At the same time, we did not have any transportation whatsoever going anywhere. So even if we harvested a little bit more corneas, that would be wasted. And the one thing which unfortunately I had to do was to do a little bit of a pay cut to the staff, which is not very good, but that definitely led to a low team motivation. But the iBank manager and the iBank director had a very continuous effort on relationship building and relationship keeping with corneal surgeons and the donor hospitals. So this, after this three work, what we set in front of us, we gradually, what we try to do in the future is we will gradually increase the activities of the iBank to keep the momentum of iBanking, because iBanking in Nepal is going on for the last, although it's going on for the last 20-25 years, but the real iBank started in 2012-13 when we started our hospital corneal retrieval program. So it is in the society, it is still young, so we do not want to want the people or the community to forget about the iBanking. So we have to keep running the show, although the number of corneas coming to the iBank will be very small, but presence of the iBank donation counselors in the donor hospitals, with obviously with all the precautions, will help us to move to the normal situation once it gets normal. And in the iBank also, the iBank manager and the iBank director would have a continuous engagement with the staff, because again, the staff are, if we let them go when there is no work, they might go altogether. So they have to keep them in the business all the time. That's what we did. Even they set the targets, which is very kind of they set the target according to the situation. So it is not a huge target like in January or February, but 2 corneas a month or 3 corneas a month, so that they will not lose the tempo of working on the targets. And again, when the situation gets to normal, they might be able to plan themselves to obtain more corneas to go nationally and internationally. And the challenges we have again now, what the government has decided is to ease down the lockdown, but because of that, the number of COVID has gone up again. It came down to 57 per day, but now we are having again few hundreds every day. So which is a big number for Nepali situation, not for the Indian situation, but for Nepali population, it's a big number. So we still have to protect our staff in all sense of the word. Sustainability of the iBank is a big problem, and we talked and we saw in the chat also that the screening of potential donors is very difficult. PCR test is almost not possible post-mortem or even the potential donors. So we are not doing any RT-PCRs to the donors. Although it came up in one of the chats is that we are doing PCR to all the patients who are undergoing corneal transplant. Even the interruption of supply chain is a big problem again here in Nepal. Suddenly we run out of different things, and then because of we do not have any transportation going, it is a big problem. And again, the patients who had transplant before and during the lockdown, it is very difficult for us to follow up those patients. Although we have I thank our surgeons that they have very open-heartedly given their cell phone number to the patients. But as you know, just calling the doctor doesn't solve the problem. So that is one of our challenges. So thank you very much. Thank you for giving me this opportunity to speak to you all. This is again, I tell you that it's a very basic kind of presentation, but I thought it is important that we all protect our staff. We have to work on the sustainability of the iBank, and we have to run the iBank continuously so that the momentum will be good. Thank you so much.
Thank you, Dr. Rita,
yes,
for that presentation and for insights into iBanking in Nepal.
Thank you, Dr. Gurung. It was the last slide was really good in the sense that can you just unshare this your slide? Yeah. That we have to keep the morale and the spirit high of the iBank staff in this tough situation. And in continuation, we would like to invite Dr. Namrata Sharma for the status, for her presentation on status of iBanking in India in the COVID era. Dr. Namrata Sharma, for you.
Thank you, Rajesh. I'll be talking to you about the iBanking way forward, as well as the guidelines which were released by the All India Ophthalmological Society and iBank Association of India. And this was version 2 in June 2020. And I think the dictum of this was that the ophthalmology will not change, so you can't change your practices as such, but the way we are doing it will change. So we have to adapt to it. This was the guidelines which was released, which was a 104-page book on different aspects of ophthalmology with 225 plus experts, 20 Zoom meetings, and 13 subspecialty societies. So these are glimpses of those meetings. And we involved every single subspecialty society, and particularly for cornea and eye banking, we had Eye Bank Association of India, Indian Society of Cornea and Keratorefractive Surgeons, and Cornea Society of India. In each of the subjects, the guidelines was done, and we are very fortunate that we did have representation from Vision 2020 as well as from the National Program for Control of Blindness. And we would again like to thank Dr. Pramila Gupta and Dr. Rajiv Garg for being with us even during those times and being with us even today. And I think collectively we would like to, of course, within the safety realms, we would like to request them to look into this voluntary eye donation program, at least in some places. So the guidelines for the various surgeries are in place, and this is the group which looked into the cornea and eye banking guidelines and delved into it, and then suggested suggestions. This has also been published in Indian Journal of Ophthalmology. The Eye Bank Association of India recommended that the collection of a nasal swab of diseased donor for RT-PCR COVID-19 is at the discretion of the medical director, and technicians and relevant staff must be given training about the PPE use and other precautions during retrieval to reduce the risk of acquiring infection. And although these guidelines were there, they are advisory, but each eye bank should monitor and consult their local THOTA, NOTO, SOTO, ROTO, State Health Authority, NPCB, and their instructions from the local state government for starting the services. Exclusion criteria is like everywhere. If the disease has been tested positive for COVID-19, or there is history of fever, or the symptom which is of COVID-19, such as cough, shortness of breath, unexplained fever, diarrhea, loss of smell, loss of smell and loss of taste, and individuals who have been exposed to confirmed or suspected COVID-19 within the last 14 days. Then any evidence of conjunctivitis in the past, if you are in the red zone or living in the red zone area of the zone defined by the Ministry of Health and Family Welfare, and if there's any history of ARDS, pneumonia, or CT scan showing ground glass opacities. Because these are the symptoms for people who have to do the screening, especially our eye donation counselors who would go and screen the diseased for these symptoms. Then this is the algorithm that we have suggested that we follow, and again this is published. And I would like to thank both Rakhi as well as Dr. Sharon D'Souza, who's also with us here today, who helped to in the formation of these guidelines. So whenever you have a diseased donor in the hospital and confirmed case of COVID-19 or exposed to confirmed case of COVID-19 in the last 28 days, or lived or has visited any affected area within the previous 28 days, one has to assess the clinical situation. And if there is evidence that it is associated with COVID-19, the donation does not proceed. But if the symptoms are not there and the screening for SARS-CoV-19 is positive or is inconclusive, again, the donation doesn't proceed. And the donation only proceeds when there's no epidemiological risk, there's no clinical situation which is compatible with COVID-19, then only one can proceed with the donation. These are the urgency-wise list of the corneal procedures. This have been modified from the RANSCO chart, which was shown. Emergency procedures, semi-emergency, and the elective procedures which have to be taken. This is courtesy of Eye Bank Society of Rajasthan and the Shroff Charity Eye Hospital. We are thankful to Dr. Swati Tomar and Dr. Manisha Acharya for this. And this is essentially how the training of the eye banking staff has to be done in terms of wearing the PPE. And I think this is something which we need to do at in all the zones. And Dr. G. Mukherjee sir has promised that this kind of a training module would be started for all the 5 zones. General functioning guidelines is, of course, we know that in India, a lot of places are there where enucleation has been the mode of collection of the corneas and the corneoscleral rims. But we would recommend that only corneoscleral rim excision be performed and avoid whole eyeball enucleation. Cornisol has done a great job from Orolab, intermediate preservative media. It's been extremely useful for prolonged preservation of the donor corneas. And of course, if not utilized, the corneas have been shifted to glycerol also. Recovery procedures mandatory require double contact of povidone iodine to ocular tissue before retrieval. And this needs to be emphasized that double contact time povidone iodine should be done in all cases, because povidone iodine kills the virus. Also, the disposable PPE kit has to be worn. The double-layered masks have to be worn with the N95 mask, and they have to be cleaned periodically. The MK bottles, cortisol bottles, flask gel packs, instrument tray, etc. can be cleaned with surgical spirit, alcohol wipes, or freshly prepared sodium hypochlorite after recovery and repeated in the eye bank. And again, all precautions have to be followed. Some people have even recommended UV light in the laminar flow hood for 30 minutes. I do not know if any eye bank has it, but that has been recommended. And we can have to wash hands thoroughly, frequently with soap and water. And of course, the Arogya Setu should be on the phones of all the staff who are present in the iBank. Housekeeping protocol has to be as shown, as is recommended for all hospitals and all clinics. And these are just general steps that when you reach your house, before that only you tell them that you are coming, so that the sanitization procedure can begin outside the house. Wash the hands, and use the tissue and sanitizer, wipe the items placed in the box. And then when you go home, you change after taking a bath, so that your family members are protected from this. This is the declaration of screening form for COVID-19, which was specially designed. This was for the patients, and this was for again for the treatment consent form, to tell the patients that if you undergo a corneal transplantation, they don't blame us later on that this caused COVID-19 infection if they do have it. Of course, all social norms of waiting hall guidelines have to be followed by the patients, whether it is screening desk, registration desk, or patient waiting areas, billing counter, etc. Similarly, the breath shield for the slit lamp has to be there when you are examining, with proper PPE. And these have to be cleaned appropriately after each patient has been examined, and proper sanitization has to be followed. Again, when you have a negative for SARS coronavirus test, only then the surgery can proceed. And this is something that is being emphasized in our hospital, but I know that this is variable for other hospitals and other centers. And in the operating room, the surgeon wears full PPE, again with the face shield is actually difficult, but maybe goggles for operating. And biomedical waste disposal has to be done appropriately. Post-op care for these patients is done maybe on the initial post-op period on the slit lamp, and later on in teleconsult with the help of teleconsultation. These are the guidelines that we published. Now, as far as coming to the statistics, note that the corneas collected in 2020 versus 2019 in the same period have dropped down immensely, and this is the data from the SightLife India. Then again, the corneas which were transplanted from the SightLife partners have also dropped down drastically in the months of March to June, when the lockdown was announced. And this is from the iBank Association of period during the lockdown period, when obviously no corneas were collected, only therapeutic transplants were being done. Now, we did a AIOS EBI survey and teleconsultation. We found the question was whether teleconsultation or teleophthalmology for patient consultation should be done or not, and almost 68% said that it should be done. Expectation to get back to normal cornea practice, almost 80% said that it will take 3 to 6 months, or even more than 6 months. Special training to the iBank staff was being done and was started by almost 80% of the iBanks, and 19% said that they had not yet started it. Then if you look at the EBI survey, again, collection in the pandemic era, although it started to pick up, but it was not as much as is generally there in the same time during the same period last year. And likewise for tissue distribution also, which was almost 1/8 of what it was during the last time. And this is understandable. The cortisol use has drastically increased by almost 45%. And I remember this figure last year was hardly 16 to 18%. Glycerol is another thing which people were using more. This was not there at all last year. And MK media was a third of cases, and Optisol was also there in some of the places. The nasal swab testing was not being done by 60% of the iBankers, and 13% said that they were doing it, and 26% said that they were not collecting any eyes. And of course, no iBank in India has collected tissue from SARS-CoV-2 positive patient. 35.7% iBanks procured tissue with clear negative COVID-19 diagnosis. Half of them rejected suspicious cases such as donors with respiratory pathologies, and 10% had no collections at all. Surgery only after COVID-19 was being done by 40%. They said they would like to do it, and 37% said that they were not doing it. So again, if you look at the transplant surgeries, they are there, but of course they are much less as compared to what was being done last year. So to conclude, COVID is an enigma, 19 is an enigma globally, and it has led to unprecedented infections and death. iBanking has taken a major hit, and we have to follow the recommendations and follow the guidelines. And as of now, also the advisory from the various governments, state governments, as well as from the government of India.
Thank you, Dr. Namrata, for highlighting the issues related to the iBanking in India in this COVID era. And we all understand that there's so much of variability, so much of variation in terms of, the donor screening methodology, in terms of whether we should do COVID testing in the recipients. There's another concern is that increasing cost of processing of the cornea. So many issues are there. So definitely we will have the inputs from the panelists. Before that, we would like to go for our last speaker of this session, and that is Patrick Emery of SightLife, and let's have his viewpoint on this issue.
Thank you so much. Good evening and good morning to everyone. It is such an honor to be here with all of you today, and I'd like to thank, first of all, to Dr. Mukherjee, Dr. Pramila, Professor Namrata, EBAI, and AIOS for having me here today. Can you see my screen?
Yes.
Great. Well, as we all know, this pandemic has turned our lives and the iBanking industry completely upside down. Tonight, I will share updates from across geographies and why I am optimistic about the future recovery. So the declines globally and India have been staggering, as we all know, and any disruption of this magnitude is naturally destabilizing. But with 80% of the corneas transplanted in India coming from just 20% of the iBanks, I believe we must act to ensure the viability of this critically important and globally recognized iBanking system in India. So this graphic demonstrates the declines across geographies and the progress of recovery. The declines started in China in February, as we know, with a 50% reduction fairly quickly. Moved across the West, and in India and Nepal saw a dramatic impact beginning in March. Ethiopia was later impacted in April, which was one of the last regions to be impacted. And the recovery is following a similar trend. China has actually recovered to 110% of prior activity following the strict containment measures in the country. And while the recoveries in the US, India, Nepal, Ethiopia are proving to be slower, there are some encouraging trends. These encouraging trends are the result of perseverance of individuals, many of which are on this webinar, and we'll discuss a few of these innovations that have come through. So different challenges across countries, but great opportunity to share learnings, as many of the solutions that have been developed in various geographies are applicable elsewhere. First, starting with India, limited access to high volume donor sources such as mortuaries, wards, and voluntary donations for the institutions that have started to try to increase donor volume. Seeing great success with iBanks working with mortuaries and wards to find where they can obtain donors from patients who are not coming in contact with COVID positive patients. There are examples of mortuaries separating their facilities into COVID and non-COVID areas, which is allowing iBanks to then maximize donation wherever possible. In China, iBank personnel, for the most part, are barred from entering all wards. And for a short period of time, this completely stopped donation in China. However, they were able to strengthen their relationship with individuals who were permitted to be within the wards. And in China, that group of individuals was the OPO, or Organ Procurement Organization staff. They partnered with the OPOs. They were able to train them to approach more effectively for cornea donation and actually facilitate donation. Well, I know in India, we don't have a highly prevalent OPO presence in most of the institutions. It did demonstrate the importance of just continuing to build on those relationships that we have with the board staff of various designations. In Sri Lanka, they're actually seeing an oversupply of tissue. However, their eye banking industry and their eye banks in the country were developed to not just meet their local need, but to provide high volume of tissue internationally. Now, they are unable to distribute tissue internationally due to high shipping costs, just because of there are not enough flights. So they are actually working with the government to drive local demand within the country, so that more locally procured tissues can be used. In Greater Asia, inability to import tissue from the US or import tissue from Nepal or Sri Lanka has been pretty much a blocker for transplant in most of Greater Asia. These limitations are because the flight options are either too expensive, they simply don't exist, or the risk of flight delays or cancellations just makes the possibility of importing tissue not feasible, which is unfortunately they don't have in many countries in Greater Asia any eye banks to even attempt to scale up. And in Ethiopia, limited access to medical social history for assessing COVID-19 exposure stopped eye banking for a short period of time. However, they were able to work with the government to allow for the government to provide funding for 4-hour COVID testing for all of their donors. Now in Ethiopia, the majority of donors come from patients there may be very limited information about the circumstances of the death or their medical history, because they come from oftentimes unclaimed bodies. So this ability to conduct COVID testing is critical in Ethiopia, and they are requiring a negative result. Now, the loss of tissue placement revenue, as we know, puts a great deal of risk and jeopardizes the institutions. And I encourage leaders on this call and leaders of eye banks to think outside the box for ways to maintain our talent that has been built up over so many years, build the stability of the eye banks, and prepare for a recovery. Becoming fully aware of the eye bank operations, where is every rupee being spent, and how does that rupee support long-term viability and recovery of the eye bank? Understanding what effort is currently contributing to the recovery in the eye bank. What is every individual doing? We know that many staff are not able to perform their normal duties because there just is not tissue coming in the door and going out the door. But how can those individuals be repurposed to support the recovery and ensure long-term stability? Explore all options to increase revenue. And there are many institutions who are actually seeking external funds through fundraising from governments, local governments, international governments, USAID, and others. How can we increase revenue in a time where generating tissue placement revenue is just not feasible to the point that we require? Minimizing operating expenses that do not support a recovery or are not enabling us to retain talent. The staff in these eye banks in India are incredible. They're some of the best in the world, and we don't want to lose them. We need to make sure that the staff remain engaged and they continue to see this as a viable career. And so thinking about how we can minimize our other expenses so that we can continue to retain staff, because we will need them. And just bringing a shared understanding within the eye bank that this recovery is everyone's job. Rallying the eye bank teams around the recovery can have a great galvanizing effect and bring the most creative solutions to the forefront. And so very much encourage the eye bank leadership to bring the team into this challenge together and come to shared solutions. Now, we have all invested in building this ecosystem and must protect this investment. As Heather mentioned on her talk, that this is an opportunity where we are not as busy with day-to-day eye banking activity as we typically are. This is an opportunity to focus on our short-term and long-term strategy. While this is a devastating time, the lull of activity will not last, and we have an opportunity to work with the staff. And use this extra space in our brain and in our days to think about how we can achieve our mission over the next 10, 20 years, and what we can do in the next 6 months to ensure that we're able to fulfill that. Engage the team in financial planning, ensuring leaders are fully aware of all areas of eye bank finances, build plans to expedite the financial recovery, such as eliminating recurring costs, different ways that they can seek international or local aid, and bringing the team together for structured development activities. We know that team development is an oftentimes deprioritized activity because the teams are just so busy. Engaging the teams in online learning courses, assigning team members to revision areas of iBank operations, or engaging in continued iBank public awareness. The leaders on this call have already accomplished so much. You all have grown the iBanking industry tenfold in over a decade. And I'm very confident that together as a team, we can lead these iBanks and lead this industry to a full recovery for a prosperous future. We all know the patients are relying on it, and I look forward to supporting you in the process. Thank you so much.
Thank you. Thank you, Patrick, for giving that overview. And now we will come to the interactive part of the webinar. We have a lot of questions which are there for each one of you. And I think first I would like Dr. Rajiv Garg and Dr. Pramila Gupta to respond to this. Can NPCB provide some health benefits for eye donation counselors and recovery technicians?
No, we don't have any scheme to provide any, what should I say, incentives or any thing for the iBank technicians per se.
And also there is another question which is there from all of us, in fact, all the iBankers. What about the additional cost of the PPE kit and the COVID test for the donors? So can NPCB give some additional grant amount per cornea for new extra additional items, you know, such as PPE, face shields, etc.?
I think for this is a long process. We'll have to put it up to EFC, and only after we get a permission we can do it. We can put forward this demand to our EFC.
Yeah, so I think this is something which, ma'am, one has to look into.
Yes.
These are the two things which one has to look into. If there are any questions.
I have a suggestion, Namrata, here.
Yes.
I know that government there's no such things which government can provide in this regard. I know very well. So we'll have to have some other ways to generate money for COVID testing for donors as well as for recipients, and PPE kit for our technicians and counselors. So maybe we can rope in some big NGOs in this. If not that, then we need to have a resources. Maybe people who are involved into a practice, they donate money for this thing, which is a need for maybe for next 6 months to 1 year. So it is not a big amount. If I see COVID testing for donors, only we require, as far as patients are concerned, it is being done. The donors, each donor 2,500 rupees. In India, we'll have maximum of 20,000 donations. So it's not a very big amount. We can generate that money if we work together. I think that's the only way we can generate something for this. Pasak is not happy with my answer.
Life has calculated that for pair of eyes, they have to spend extra 1,000 to 1,200 rupees. They have calculated that, taking into account of all the things that are required during the COVID time, and they have given that figure, 1,000 to 1,200 per eye.
I think iBank Association India can mobilize this thing. If people can donate for PM fund in lakhs and crores, why not for this small thing? We require hardly 20-40 lakh rupees to sustain for 1 year.
Dr. Radhika, you would like to comment on this?
I would like to say the same thing, that it's very difficult for iBanks, particularly the ones who are depending on their own resources for the staff. And also as such, the NPCB amount is a big help, but it is after all a subsidization of the cost. The amount of money which is given per donor does not actually cover the entire cost, but it is a subsidy, and then they are supplementing it with the processing fee or as rightly said, NGOs, or they have their own sources, they have donors, etc. And now this is an additional cost. One is that the number of tissues that they are able to place or distribute has become less. So there's a drastic reduction in their revenue. And on top of that, an additional cost of the PPE, masks, etc., and maybe more COVID testing. So I think per cornea transplanted, I would say it looks to be about an additional 2,000-3,000, maybe 4,000 rupees if you're going to include the COVID testing, etc. So I feel that we'll really have to think about it, how to do. As Dr. Chityal correctly said, it is really going to be difficult to expect the government to provide it all. Maybe we just have to increase the expense for the surgery. We have to, after all, there are some people who can afford to pay for the surgeries. And the people who cannot afford, and the therapeutic or the extremely needy, for that, then we have to find government support, or they have to get operated in government hospitals. So the tissues can be transferred to the government hospitals, and the government hospitals can give them back the money. If maybe even NPCB allows the government hospitals to use the per cornea collected to support the tissue processing fee to the private side. So a little bit of flexibility in how the money is going from one pocket to the other pocket.
Okay.
Can I say something?
Yeah.
Since we are a community eye bank, the only way that we are looking into it is that we already survive on donations. So we don't have too much of support because we are distributing 50% of our corneas to the government hospital free of charge. So the only way that we are looking, EBSR is looking at it, is that we increase the processing fee, which would anyways cost to the ophthalmologists who are doing in private, because we can't charge anything from the government hospitals. So sustainability is becoming a real issue with EBSR in coming months, and we are already paying salaries and other things. So I don't think that how would be the survival of community eye bank or standalone eye banks in future. So that's a major concern which is there.
Yeah, even in Mumbai, we have a community eye bank, and what we are doing is we are tapping our usual donors, and they are coming forward for this. So, for example, I have talked to our Rotary, and Rotary is quite giving. They've given some grants for this to tide over the crisis. So I think for community eye banks who are dependent on donations from outside, we just have to tap our donors for increased amounts.
And I also feel that ultimately we can also tap into industry and other companies, technology firms, Bill Gates foundations, other sources for managing the current situation in the crisis. So we have to think a little bit outside of the box in order to be able to receive collaboration from other networks as well.
Dr. M. Srinivasan is there with us, sir. You are collecting, I believe only there are 2 or 3 eye banks who are collecting eyes. So you're collecting eyes, you're doing a RT-PCR for them, or based on history?
See, Tamil Nadu, the infection rate is very high, like in Delhi, and we collect mostly about 10, instead of 200 corneas, same period we are having about 6 or 10. And we select HCRP only hospitals not admitting COVID patients, and we don't do RT-PCR for donor or recipient.
And the collection is both
very low.
enucleation as well as corneoscleral or both of them?
Pardon?
Enucleation, you're doing enucleation and...
No, in situ excision, we are using Cornisol in HCRP. Community eye donation, we have not started again.
Okay.
Regarding this, the previous speakers, he was talking about donation from industries. Now in India, not even in India, globally, all industries are bankrupt. They don't have any money. They are closing. They are not able to pay salary for their staff. So it's not possible to raise donations, at least now. So we have to only increase the processing fee. It will go up to 6,000 rupees per cornea. So we have spent Corneal 2 vials and RT-PCR about 2,500 rupees for both. It will be 5,000. And then other routine tests, serology tests. And more than that, distribution. There is no transport for 4 months in Tamil Nadu, even within districts. So we can't send the tissue. No vehicle is allowed. Only e-pass provided only for attending funeral and your own family weddings. Nothing else. So even if you get tissue, you can't use it. Recipient cannot attend the hospital. You cannot send the tissue to the surgeon. That's the problem.
Okay, thank you, sir. Dr. Basak, sir, you still have an overload of tissues or
No.
tissues have come down?
It is drastically has come down, and we are actually lately we are collecting from the month of May, and gradually we are increasing maybe 13, 14 pairs in a month, and we are utilizing almost at 90% level because it is already screened. And one thing I want to share that we are collecting from home also, home death, provided we get a good conversation with the treating physician. Suppose a family member died at home and we are doing discussion with the family members or what happened for last, say, 3-4 weeks, and the treating family physician, we are talking. And family physician is also writing 2 lines at the end of the death certificate that I am following up this patient for last 4 to 5 weeks, because many people are not going to the hospital for treatment. And if they write at the end of the death certificate, we are requesting them, and then we are going to collect it. That way we are collecting home collection, and maybe it is 40% are from home collection. Otherwise, like all guidelines. But regarding PCR, RT-PCR, it varies from state to state. So in Bengal, it is for normal COVID patient, it is a waiting list of 4 to 8 days. So how can you request the government to go for RT-PCR for a disease for only eye collection? It is there is no logic in it. Even mildly symptomatic or contacts, government is saying no, you stay home, quarantine. If you will have symptoms, then come for RT-PCR. So who will go for RT-PCR? Government is not allowing for RT. Not only Bengal, it is also true maybe for Telangana and other states. And private labs are kept that you cannot do more than 100 tests in a day. So these are different in different states. So we cannot categorize that all tests can be done. Those who have options, they can. AIMS people they are fortunate enough. They have every gadgets and everything. So you can do that. But we at the periphery and we are a different state. So it has to be respectfully to the state government also.
I think, Dr. Basak, Samar Basak has a very nice point here. In today's time, the most non-COVID deaths are going to be at home. And if you are in a green zone, as Pramila Madam was saying, if it's not a red zone, then that can be a safe for us to collect tissues. And I remember I spoke to Madam also 1 or 2 weeks back. Like if we have a COVID test, sometime what happens, the death may happen in the hospital, but the body is taken home. And if COVID test is negative in that scenario, then we can, I think we can take that tissue. But Basak, you are right. I think ultimately we need to have a green zone, and if the Namrata, what she talked about.
The only thing is that there is no green zone now. There is no green zone in the country, except one pocket Lakshadweep and Sama. There is no green zone. So you have to actually inquire a lot. You have to ask many questions to the family member. You talk for an hour and talk to the family physician, because many people in a semi-urban area, they are not going to any hospital at the last time. And mostly these people are aged people,
Yeah,
like
absolutely.
70 plus, 75 plus. They are not young. The tissue quality is also, I am telling, is basically it is like not very good quality tissue, but it is good for a therapeutic and tectonic purpose. I did only 3 EK in this period, but otherwise we have done many therapeutic, tectonic, all kind of
3
drafts.
EKs is a very large number in this period. Dr. Geeta Iyer and Dr. Rajesh Fogla both are there. Geeta, can you tell us about the SN status, Shankar Netralaya? And Rajesh, tell us how many EKs have you done and PKs during this period?
Yes, Dr. Namrata, I think we, like Dr. Srinivasan mentioned, in Tamil Nadu and especially in Chennai, we are in a really bright red zone as far as the infection is concerned. So our retrievals have been very, very less. Being a tertiary eye care institute, we get a lot of, we do have a sizable number of patients who require therapeutic keratoplasties, but unfortunately the supply is not matching the demand, which is what we wanted to ask. One, we have not been going for home collections as we've been following the EBI guidelines. Two, most of the hospitals where we retrieve our tissues from are all COVID hospitals in Chennai. So the question is, if there are non-COVID deaths in a designated COVID hospital, then can we actually, take the tissue from a COVID hospital from the non-COVID ward? Because as of now, we don't really have any non-COVID hospital from where we could actually retrieve tissues. And if we are retrieving tissues from, non-COVID deaths, then what is the duration after the RT-PCR? Like if it's been 48 hours before death or 72 hours before death, what is the validity of the test in terms of the duration before? Or does the test really have any role to play at all? Because right now we are in a tight spot where we need tissues, but we are not able to source them because of the guidelines.
What about Rajesh? What about you? How many?
Yeah, we have the advantage is that because MB Prasad is located in the same city as ours, so any infections that require any kind of therapeutics, we have been referring to their center because the eye bank being located there, it's easier for them to manage and do the surgery. And optically, yes, we have also done the 3 and primarily it's been because tissues are not available. Even at MB Prasad, the eye bank, they are prioritizing, and most of the tissues are for emergencies. Not when you don't have tissues for tectonic procedures to save the eye, I don't think it makes sense to try and do elective surgeries at this point of time, which can be done at a later date.
Thank you. And now I think LVPI seems to be the largest source of donor corneas. So Sujata, how are you collecting RT-PCR? And I think your figures are the highest as of now from all over India.
Okay, but no, we don't do we are not doing RT-PCR. For patients also, not for recipient. This antigen test recently have started only for the patient who are undergoing GA procedure or aerosolized like oculoplasty procedure. Collection mostly is now no voluntary cases. And in Bhubaneswar, we have restricted to only one hospital, one HCRP program. Because we are collecting only for the accident and hanging and all suicide cases, most of the corneas are good quality and 100% utilization. So it's anyway, our collection was in Bhubaneswar, it was never from voluntary. It was mostly 95% is from hospital, corneal retrieval program.
What about Sunita is here? Sunita Chauresia.
Sunita was there. Okay. I don't know what happened. Yeah, there also, if Sunita is not there, drastically it has reduced because it is like internal distribution goes on. We have sent Hyderabad, we have got cornea from Hyderabad. So all 4 centers are doing transportation amongst ourselves.
But I know hanging cases are not safe, now with the COVID scenario, most people they go through this. You should be more careful.
No, the history definitely the council, the technician are asked to screen about
You never know, they must be suffering some mental disorder.
Yeah.
I have a question. I have a question
Dr.
to all
Namrata, yeah,
panelists.
sorry.
If I can make a comment here, like at PGI, in PGI, even for doing minor procedure, any patient admitted to PGI or any patient taken for minor procedure, he has to undergo COVID test. And we are, for last month, we have done maybe collected 4 pairs of even optical PKs. So what is there is even after that, we are doing a RT-PCR. So already there's a medical auditing of the patient. Once the patient is admitted into the hospital or undergoes some procedure, in event of death, we are doing again repeating the RT-PCR after that also, because patient may contact the disease during hospital also. So that way auditing is sort of complete, and that way, though because initial guidelines were not clear, so in the month of March, April, and May, we didn't do much of the collection. But in last month, we collected 3-4 pairs for therapeutic and 3 pairs for optical PKs. So that's how we are going about it in PGI.
I have
IBAN.
a question to all panelists.
Yeah.
So the question is, the big institute like AIMS, PGI, or others, are you doing serosurveillance for your staffs, including doctors? Anybody is doing serosurveillance with antibody?
I don't think anybody does.
Then you might get some answer. Are you doing anybody in the AIMS, PGI, or in Aravind or LP Patra, the Shankar Nethralaya for stuff? Because what I want to we have started recently with the government kit with the Virology Institute of Virology, Pune. We have started from this week. And you know that even among the staffs and doctor, we are just doing, we will be going through this month, and we are at present 18% positive without any symptom, antibody test. So what we are talking about, the RT-PCR, etc. How many days, how many times, how many weeks you will go for RT-PCR, and you do not have resources? Probably antigen test is the only answer, though the sensitivity and specificity at 60% level, RT-PCR is 70% level. But if you do serosurveillance across your staffs, you will see, we are thinking that the hospital is the only source, but other sources, hospital you are spending 6 to 8 hours a day, but rest 18 hours you are actually in the other areas. So you may catch infection at any point of time. So this is an eye-opener for us, and it matches with the report from Mumbai, report from Delhi, and initial ICMR report that in Bengal it is about like 18% in the general population. It is also matching. Irrespective of staff pattern, we have done this. Right now we are just done, we have almost 1,000 staff. So we have done about just 1/10 of it, and the positivity is 18.5%. And these are asymptomatic. So this is also a lesson for us that what we are talking, maybe there are so many gray zones we do not know.
Sir, I think that is really well said, that we still don't know about COVID much. Dr. Sharon from NN, are you collecting any eyes?
Yes, we have collected, I think 5 or 6 pairs in the last couple of months, mainly for actually only for tectonic. Most of them had, perforated ulcer or impending perforation, those kind of cases, no optical. But I just wanted to, speak about some issues. As Dr. Geeta was also saying, the demand for it or the waiting list of patients is much more than what tissue is available. And same problem, we also have a lot of patients, COVID patients, numbers are rising. Most of the hospitals now have COVID patients admitted. There's no free, non-COVID hospital as such. On the other hand, from home, we still get calls of people who have died at home, passed away for eye collection. And just to highlight one gray area, Just the other day, we got a call from home, 68-year-old gentleman who passed away at home with no other known comorbidities, presumed cardiac arrest, and they were insisting on donating the eye. And then to try and push their case, they said it was COVID negative. So that, raised a red flag, and we started asking why the COVID test was done, because it's not done just like that. And it turned out that 7 days back, COVID test had been done because he's a primary contact of another COVID patient. So then this person has come COVID negative, but still a 68-year-old gentleman to have died of a cardiac arrest in a week. You don't know, what has happened or whether it is a false negative test. So these are gray areas which, there's no way to know whether to collect that eye. Of course, we're not doing any home collections now, but in time we will have to, think of whether to go into the community for our community retrieval, and those will be problems or some decisions which would be good to have answers for.
Yeah, Manisha, I was just about to come to you because you are also collecting a lot of eyes. So please tell us, how are you doing it, and pass some to RP Center, which is in your such a close vicinity, if you don't know who to
and
give.
we are also obviously dealing with the death of tissues, and it's 90 to, I think 100% is getting utilized and all in therapeutics. And last month, 2 months, it is all about, there's always a pending list on that. We collected around 32 eyes in the last 2 months. We started from June actually. What Dr. D'Souza was saying, I can just add to that. We have made 2 forms. One is a screening form, which we do at the time when we collect in the HCRP. We are not doing any voluntary, we're not doing any home. It's just HCRP currently in non-COVID hospitals, because we have some of them there. And what we do, one is the form which is there where the technician is going to screen at that point. And there's another double check form, which is like every collection which is done till the time it's getting utilized, the eye bank manager has a duty to call back the family and recheck whatever is happening, and also take the feedback. Was my staff wearing a PPE and all that, and we document that. And there has been one case where we actually rejected even after they came to our eye bank. So anything which is any sort of flashpoint, it's better to be safe. And that has really helped us. Plus the double betadine is something which is followed very strictly. And that's something which has worked for us. The only question, Dr. Namrata, I wanted to ask here, similar to what has been asked, if now most of the hospitals are COVID hospitals. So if the non-COVID ward is in a separate floor, then I find it very safe to go, because now some of the facilities are totally separated. But when they are not, if it's in the same floor or something, is it okay to collect from a non-COVID sort of an accident death or something? That's till now we've not yet started, but the way it is.
Gray zone.
Yeah, they're gray zones, but any points on that, if anybody can add to that?
Yeah, I think one question to Dr. Ritu Arora ma'am, because GNEC now is not a COVID area. But ma'am, how do you plan to restart your eye banking?
Yeah, I mean, we went through a tough time in a sense, because our sister hospital from where we do HCRP was completely COVID. And even our, as an eye center, became COVID hospital. So we just want to, I was just discussing with my counselors that we have our hospital with GB Pant, which is non-COVID. So I am planning to start my HCRP again from GB Pant Hospital, which also has considerable number of deaths, and making it mandatory for the counselors to use PPs and take the swab from the deceased for RT-PCR, and only when it comes negative, I plan to use the tissue. And even the recipient, I plan to do the RT-PCR for that.
I think there are questions that we received.
I have a question.
So
I have another question. If a recipient asks you, have you done COVID test yourself?
That they have asked several times, and we've said, no, we've not done it.
So why the questions of these things are coming? Vis-a-vis, you have seropositivity of 18.5%. So in our setup, nobody, all asymptomatic. So you put these two into balance. And now we have to try to get the gray zones questions and try to answer this. So if the recipient is asking, have you done COVID test? So the answer is no. Yes or no? Probably AIMS people can do it, you have that facility, but our state, we cannot do it. I cannot go and do my COVID test, even private lab. So if the recipient asks that why you are doing COVID test for me, I am fine.
But
so what is your COVID report?
It is
I
done.
must tell you, Dr. Basat, that recently now when we restarted our OT and started our FACOs and even squints and plastic, it just started 2 weeks back. And we made it mandatory every person to undergo COVID. And we did find absolutely symptomatic patients. I mean, the number of patients coming COVID positive is there.
No, likewise, Dr. Radhika, would you like to comment on this? RP sector also.
So I will not take a chance on this. That, the facilities. If you have a facility, I would still say that the recipient to undergo PCR.
You do not have facility, you have to take the risk.
Sorry?
If you do not have the facility, you have to balance.
I do not know how to answer that, but I think in the current time, it's an elective surgery, and definitely a recipient should undergo RT-PCR. I would definitely go by that.
Can I answer?
And the surgeon will not go.
Can I answer?
Yeah, that way.
Radhika, would you comment on this from our RPC data?
Okay. Namrata, can I?
Yes.
Yeah, like I totally agree with Dr. Vishnu, because at TGI, all patients, even for minor procedures, they have to undergo RT-PCR. In that situation, ideally, even the patient can say, I can get it from you. Ideally, surgeon should also undergo a RT-PCR to know the surgeon status. No, but ideally, we are not doing that, but at least for patients, all patients, we are doing that. In ideal situation, even the surgeon should undergo before doing any surgery. No patient can say, I can get it from you. No, patient also rights.
That is true. What we can do is we can follow the government guidelines, and government has said that no person should be refused emergency treatment because of lack of COVID test. So if any person requires an emergency surgery, like for example, a perforated ulcer, therapeutic PK, tectonic graft, you're supposed to do the surgery taking universal precautions. So we will not ask even the recipient to undergo a COVID test mandatory. Of course, now as Dr. Basak and everybody says, we do have the benefit of a stepping up of the facilities at AIMS. So for emergency surgeries, a CB NAT test is done and we get the result within 4 hours. So even for emergencies, we are doing the test. But for places where, as he said, if you don't have the facility and it is an emergency surgery, we are not supposed to refuse the surgery. We have to do it taking universal precautions. Second point is about elective surgery. And elective surgery means planned urgent cases, like for example, white cataract, or a person who's bilaterally blind, or one-eyed person who really wants to have the cataract surgery done now. So that is a procedure which can be avoided, and if for some reason it has to be done, it is recommended that one should get the RT-PCR. Coming to the surgeon's RT-PCR, see, practically for that patient, it is that one surgery. So he has to get the RT-PCR 48 hours, he or she, 48 hours before the surgery. But for the surgeon, he is doing daily surgery for 2 months. He cannot keep doing RT-PCR every 2 days. So it has to be that the patient has to trust, and nobody is forcing the patient to undergo surgery now. The patient is going for surgery. So we always tell the patient that if you cannot manage, then yes, we should do the surgery now. But if you can postpone by 2-3 months, it is better. Now the other problem is the corneas. It would be I feel very bad that so many corneas we had and we didn't put them in glycerine. And in fact, the initial time, March, April, May, it was those glycerine preserved corneas which helped us. So in future, we must remember that any eye bank should never throw away any cornea. we should put it in glycerine. And even now, if you have a doubt, like if you have, for example, the danger of going to an area is that the technician should not get the infection. But if you are, say, going for a voluntary call, like somebody said that the family is very keen on donating, so in such a case, then one can put the cornea in glycerine and then use it, because the virus will not survive in glycerine. So do double betadine. I'm just saying, because at the moment we reached a very dire state where even perforated ulcers were not able to operate. Sometimes we were even discussing doing Keenan patch and all that, and it was really like quite a desperate situation. So I think in such cases, every cornea that one can get, one can perhaps use. That's what, and yes, this point which Namrata said I should illustrate is that we are getting people positive, totally healthy people roaming around, and then they turn out to be positive. So it's you feel afraid, you don't want to harm anybody. So obviously, you have to take it that you cannot rely on symptoms to make sure that the person is totally COVID negative.
Sunita, can you tell us about the LVPI since you've joined now, Sunita Chaurasia?
Yeah, hi, madam. So just a point I wanted to add, as madam said, Radhika madam said about, every cornea, like we have to preserve in a certain way. I think what we are also doing is the pre-cut. Like, let's say we had a patient and he's one-eyed and the tissue was of good quality for doing a D6 surgery. The anterior lamellar cap also we are preserving for tectonic purpose. I know that's not the best choice, but in certain cases, like there were situations, there were days where we had no cornea. So we are keeping that cornea also for glycerine preservation, just in case we require these. That's something extra which we should also keep doing to preserve the corneas and just increasing, tissues which can be at least used for the tectonic purpose.
Rakhi, are we left with any questions which you would want to take? And Rajesh, would you want to ask any questions?
Yes, ma'am, I have few questions.
Rakhi.
Yeah. So there's the question from the participant. There's a one study which established COVID-19 diagnosis from the chest X-ray. So can this be used as a tool for ruling out COVID-19?
Can I answer this?
Sure.
6,500, 7,000.
Hello. Yeah, regarding back to the regarding this doing COVID testing in the surgeon in private hospitals in Mumbai, and especially in my hospital also, we are operating in last 3 months. So we do indirect blood testing like LDH, CRP and ferritin along with the X-ray chest. And if something comes positive or suspicious, in such cases only we advise patient to undergo HRCT or RT-PCR with due consideration to the patient. Because AIMS or PGI can afford to do RT-PCR for everyone. It's difficult to convince patients in private. And in Mumbai, we just got a permission to do RT-PCR for everyone. Previously, it was compulsory with the prior prescription and with the government hospitals recognition. You cannot prescribe in private also. So from now onwards, at least we do indirect blood tests and then we do X-ray tests. If it comes positive, then only we go ahead and if required, we do RT-PCR. Second, regarding iBank, now Sayyara has collected almost 9 pairs of cornea last month. This is a time we need to see a lot of this non-COVID hospital or small nursing home or mid-sized hospital where can actually start a HCRP program. We were actually overlooked. We will always into government hospitals or a big hospital where there are a lot of mortality. But there are other hospitals where there is less mortality. And this is a time we need to target all these hospitals. So out of this 9 pair, almost 3 pairs have come from a private hospital where we have never done any call in past. And that is a time we could start it. So the same question with patient will ask, doctor, have you done your RT-PCR or test? Yes, because I have done my initially, but then not now. I am asymptomatic. Same thing for the patient. Now in the OPD, I got just last 2 days, 2 patients were COVID positive, home quarantine, and after 15 days they come for eye checkup. So this scenario is going to increase now. So for us in the OPD, every patient is going to be potential COVID positive patient, and surgery as a indirect blood test and X-ray. If comes positive or suspicious, go ahead for the higher test.
But X-ray, is it possible in the early stage, asymptomatic area, you will not get anything in X-ray test?
Yeah, but then blood parameters do come positive like LDH and CRP and D-dimers and everything. So these are something which
Rakhi is asking about X-ray test.
Yeah, so it's not only X-ray
test will not give any clue during.
No, only X-ray is not going to help. You have to rely on the indirect blood test also.
Thank you, Dr. Rakesh.
Raki, can I add one point?
Yes, ma'am.
I know at this point of time, we are not looking into voluntary donations, but like in the last few months, we did have we did have families who were, wanting to donate their, near and dear ones. Now, we were refusing, but then it really hurts their sentiments. So, like, there were families who were really very keen, and they just came out with a history like the donor, the disease was fine, the suspicion of COVID, and the family is also fine. So I think somewhere we have to adopt the testing even for, suppose we are going to start the voice donations. That would be one reason to do a testing by some kind of rapid method. So at least we know, like, at least for the safety of our technicians, we know, like, just a confirmatory test. So we should not completely, I know at this point of time we can't be sure, but then that's something which we should explore and how to go about our voluntary donation. Because quite often, like now as a policy we are following, we are not harvesting corneas from these sources, but somewhere we have to change this practice as well.
Thank you, Dr. Chaurasia. Since we have both eye bankers and corneal surgeons on the same forum right now, is there a message from the corneal surgeons to the eye banking fraternity? 3 things which the eye bankers should keep in mind while supplying tissue to the corneal surgeons in this COVID era. Anyone?
Can I say something? Can we know if there are any glycerine preserved corneas anywhere in the country? So at least those can be used. So if there are some banks who have frozen corneas or glycerine preserved corneas, if we have some way, then we can at least facilitate. Because I'm telling you that there are times, where you're really stuck, that you have a therapeutic remedy, and I'll tell you, even those glycerine preserved corneas have really worked wonders. So it's not something that should be disregarded. And other point is, in case other countries are having surplus cornea like Sri Lanka, then they are having these, can we work out some method to get it from there? Because the Vande Bharat flights, I think, have stopped, but commercial flights are going to start. So maybe we can consider taking from other places if they have, because often they will not be using their therapeutic tissues. Other countries like the US possibly will not be using them. So we could think of a way of getting those tissues, can we?
So I know from some people, like, there is an eye bank in US which preserves cornea, whether it is in glycerol. They have all these corneas which they have a whole inventory. So I'm not sure what is being done to those corneas, because there are no takers in US for those corneas. But what about exporting to the countries where there is a need for that? So I'm not sure if some panelists can still there, but I know of the eye bank where they had tectonic corneas which were not being used in US.
This is Patrick. I can definitely pose the question to my colleagues in the US and see what is the status of the glycerin supply. I know that for most eye banks, it is sent to one organization that stocks them and then distributes them. I don't know if, I think most of the eye banks don't hold their own stock, but I can take a look and then come back to you. And I don't know, Eric is on the call as well. Eric, do you have any more insight into this?
No, I was just thinking the same thing, Patrick. It seems like the glycerol preserved corneas really went out of vogue a while ago, and I think there's only like 1 or 2 eye banks where everyone was doing some form of it, 5-10 years ago. So I believe Alabama might be the one that's doing that mostly. But the thing is that those have such a long shelf life that it's not like they're expiring anytime soon. So it's kind of a unique situation. I believe it's 2 years from preservation, if I'm not mistaken. But yeah, certainly we can take a look at that and get back to the group and see if that's a possibility. There's got to be. They're usually used at this stage of the game for like glaucoma shunt covers is typically what we're seeing that for. We don't tend to use them structurally, but I could certainly see a need for it more in countries that are requiring the tissue for something like the structural or prevented cornea melt, something like that.
Okay. Yeah, I think it's a really good question. And I know that the cost to recover them, typically it's tissue we already would have recovered and would have discarded. The cost to preserve it is very, very minimal. And so even if we're not currently preserving it and sending it off for distribution, perhaps we could look at doing that, or at least preserving our tissue that is safe, but not suitable for optical. So great question. Thanks for bringing that up. I will check on Monday. US time, and then come back to you.
We have few tissues which are glycerin preserved, and we have given the tissue to the National Eye Bank, but we still have some tissues left which are glycerin preserved, which are there with us.
No, but one question is there any legal issues? Is there any sort of bilateral mutual contract between the two countries for importing and exporting tissues? Because lately there was issue in ICMR where people were sending blood samples and other things to other countries for the testing. So there is some legal hassle. I don't know what about the eye tissue as far as mutual understanding between India and rest of the countries is there. I have no idea. But
It is okay to import tissue from the US to India. It is okay, but tissue cannot be sent from India to anywhere else.
All right. Okay.
In the past, we have received tissues from Nepal also. When they had excess, they had sent tissues to Delhi for the consumption to National Eye Bank, because they don't have a law which says they can't export the corneas.
I think these points that started by Dr. Radhika and then move forward into all the discussion brings up the importance that perhaps we need to find a global platform of communication amongst the eye banks to find out the status of their particular eye banks and who has more. Because if we find that information out on a public health level, I think that'll really improve the future. So finding a way for eye banks to communicate more effectively and quickly, especially if they have tissue or if emergencies arise, would be pivotal during these times.
Hi, this is Heather. So the Global Alliance have a project in place which we've been promoting for a while, which is to develop a global data project to collect that information annually. So the problem is at the moment, we only have one stat which we keep quoting, which is fantastic, which is that there's 12.7 million blind people. It came from the same study from Gain et al. Fantastic paper. But we need to do it annually, that kind of data. The problem is most countries don't have the infrastructure to have someone sitting there doing the data. It's really difficult to get people, particularly now when we're facing a global problem, to have people dedicated to sit there and do it. It's a long-term goal. So for us to have such a platform in place like that, it's going to take years. Just to get the basics of a few countries, it'll take me about 4 to 7 years to build that. So we're not going to have it straight away to help us with our COVID pandemic. It's a long-term goal, but not something we can do straight away.
Thanks, Ida. Dr. Rajesh, do you have more questions? Dr. Sinha? Okay, I'll ask one more question. Is it mandatory for the eye bank professionals to get their COVID testing done? So how many of you are doing the COVID testing for your staff? And if yes, are you repeating the test after 15 days or 28 days?
Rakhi? Yeah.
Yeah.
So we have done COVID testing for all our staff who are actually right now on the field, because there was some notification from Maharashtra government and there was a confusion in one hospital. But then based on the recommendation we did, everyone was negative. We didn't had any idea how to repeat the test after 14 days, 28 days. They informed us if there is any symptomatic staff or any high risk contact, then only to repeat it. But then currently we just did it based on our government notification in Maharashtra.
Okay, thanks. Eric, Are you doing the testing, COVID testing for your iBank staff?
We are not doing COVID testing for our iBank staff. What we do instead is, first of all, the vast majority, probably over 80% of all of our staff are working from home right now. So we're really kind of, all of the ancillary non-recovery staff aren't in direct contact. The people that are in the lab have to undergo a questionnaire every day before they go in. They have to socially distance, wear masks when they're in the company of anyone else. So we're really practicing those kind of protocols to prevent spread. With regards to disease potential spread or transmission through recovery, we're not as concerned about that because of all the additional protocols that we have. And again, as any iBank will tell you, you treat every patient as though they're contagious, infectious. So we're just ramping up the recovery protocols and the barriers and everything like that, just reinforcing that you have to treat every single patient every time you walk into the hospital as though you're walking into an infectious disease ward, basically. To date, we haven't had any issues with it, and we've been, recovering for at least emergency purposes throughout this entire time. So we feel like the practices are pretty well, even in spite of the fact that the U.S. pandemic is exploding and hitting second waves in a lot of places. We haven't really been directly affected by that oversight.
Thanks, Eric. Dr. Chaurasia, you have a very big team at LV Prasad. So are you doing the COVID testing for them?
No, we are not. It's yes, if somebody has symptoms, it's only on those grounds. The other thing is, I think Rakesh can answer. So if all IPTech employees are doing the testing, how frequently is that, and who is paying for that? Because finally, if somebody has to get the testing done, you yourself have to invest in the testing, diagnostic. All that is the person has to do that. So unless the patient, the person has symptoms, what would be the need to do that in the first place?
So since, as I told you, we had a government notification and there was a confusion. So we did all our 4 staff who are on the field, like 2 are on the field and 2 are on the iBank who are processing the tissue. So we did testing for all of them. Entire expenses was done by iBank, and even we had given additional insurance for all our staff, because every staff had a fear of working again in any of these COVID or non-COVID areas and a suspicious area. So that entire cost having been taken by iBank. But then we did it for all our staff, and then it was negative. But then if anyone had a symptoms, yes, definitely we'll repeat it. Or anyone has a high risk contact coming with any of the nearby area where they stay, we have to repeat it.
I think, Raki, the situation may be different state-wise, because here, even if somebody do the testing, it can't be done without a doctor's prescription. So it has to be like, if some testing has to be done, it's in our in-house physician. He has to write the test like it is required, and it can't be done just anywhere. It has to have a collaboration, and only some specific centers have to do that. So
same in Bangalore
everywhere.
Yeah, so till June in Mumbai, we had the same situation. We could not prescribe any of the tests on our own. But since July, the government opened up and allowed to do a testing for us, including a rapid test. So then we did it, and based on the recommendation, and they allowed us for all iBank persons or any of the even hospital staff who are in going to be a high risk contact or anybody, they are allowed to do all the testing.
What we do in our hospital is that we're not doing the test, but every day before the person comes in, if it's the duty day of that particular person, it may be it's a medical or a non-medical person, there's a form which is there, which is mandatory to fill before the person enters. So just like a testimony that there are no symptoms, nobody in the family is having anything, but that's something which has been followed since the lockdown opened. It was from that day and the entire data. So that's some sort of a screening which is done, which and we're doing the test only for those who have symptoms, not without symptoms.
Okay.
It's like a hospital policy.
Even at only symptomatic. Yeah.
Only symptomatic. So Dr. Hitendra, the next question is for you. Your iBank is very focused on the awareness activities, like most of the iBanks are, but we keep hearing your name in the newspapers for the awareness activities. So with this pandemic, how are you planning to continue with your awareness activities? And this is for all of you when the donation fortnight is coming. Are there any plans from your side that how will you do that activity?
Raki, I don't think for this year fortnight we would be planning anything, and if at all, that will be not be a physical activity. Those will be this webinar kind of activities. We can kind of ask some celebrity to get this message of eye donation and increase the awareness, basically. And as of now, since we are a community eye bank, and most of our eye donations are voluntary eye donations, it is completely kind of stopped. So we will have to work hard to start the eye banking again.
So I would say this is a time where we have to go entirely virtual. So all the patients who have undergone eye transplant in this COVID time also, we need to start getting video testimonial for such patients. Patients are in waiting. So such patient also has to appeal to the community for going for eye donation. And all these videos has to be publicized everywhere in India with all our Facebook and other platforms, because there is a need and there are a lot of patients waiting. So all our cornea surgeon can provide such video who are in waiting, and then eye bankers can promote such videos to their community. And as I told, just tap all the new hospitals who are actually for HCRP. That is something we can really do it right now.
Thank you, Dr. Rakesh. Thank you, Dr. Hitendru. One last question from my side. We have seen from the data that not majority of the eye banks have seen the attrition or the voluntary leaving of the job by the eye bank managers, technicians, etc. But definitely everyone feels that there is a requirement of doing something to boost their morale, to give them the message that there's nothing is wrong in their life. So are you doing any kind of psychological training or like keeping them mentally fit also? Are there any efforts by your side?
The biggest thing as a medical director or as the owner of the hospitals, as a doctor, we can tell our staff is we are with you. Don't worry, you are not alone. It's COVID can be there for anyone, for you or for me also. But as a team, we need to stand together and then support whenever need comes. So that is how we have to support our staff first. The work wise, the career wise, financial wise, everyone will improve over a period of time. But first thing, as a team, we are together.
I think now more or less there's some kind of acceptance also in the community, because the way cases have risen places, and many people testing positive and recovering out of it, and positivity related to related to recovery of patients with COVID test positive. I think that is also in a way like people are understanding, like even if it happens, they will recover. So there's some bit of positivity even if somebody is tested positive compared to what it was. Now the knowledge of treating the conditions is also way better. So I think somewhere people are kind of more aware of the situation. They are taking more precautions certainly. They're not kind of overwhelmed or really worried about it. Because now you come across many people who have come positive and then they have recovered and they are doing fine.
And I have seen Dr. Mani
outside, like distant from the hospitals. You should keep them engaged. Like we have initially a lot of virtual WhatsApp class, exam, new protocol. Keep them engaged in something or other.
So I have seen Dr. Manisha, Dr. Shroff Charity Eye Hospital, sending on the Facebook the messages regarding the eye bank technicians as a Corona warrior. I think these small things make a lot of difference in the life of technicians, counselors, when they are recognized as the COVID warriors with the doctors and the other healthcare workers. So that's definitely very helpful. Dr.
This is the time when we need to celebrate success, and that these are any good point has to be celebrated with the team, and a lot of appreciation and acknowledgement has to go away. And I think you name them as Corona. Really happy on that. That's something personally.
Yeah. Thanks, Dr. Manisha. Dr. Namrata, I don't have more questions with me now, so if you want to take over.
Dr. Mukherjee sir is there. I think we can wind up. I can only thank everybody for being there from all across the globe and also from our part of the country, from all across the zones as well, from all across the institutes, the major institutes of the country. And we did try to, I think Dr. Pramila Gupta is not there, but we did try in our own, soft manner to tell her that voluntary eye donation should be started. I'm sure she would be forced to again revisit this, and it will be a good news if voluntary eye donation is started, especially in those areas which are green, and especially, of course, after taking all the universal precautions. Thank you, everyone, and we would have Eric, thanks again for staying till the very end, and Patrick also, thank you so much for being here. You answered all the questions on the chat box, Eric. Thank you again for that. And we look forward to starting iBanking in a big way again as soon as the conditions become safer and better.
Thank you. Thank you.
Thank you.
Thank you so much.
Thank you.